We're live. Howdy, Aaron Boster here, and thank you for learning about MS with me. It is Sunday. It's beautiful out, and I've just had a hankering for jumping online, hopeful that some of you might want to join me. I didn't do a good job, again, of prompting or promoting this ahead of time, and I'm hopeful that some of you in the interwebs will find me and join this global online village. It's my goal today, if some folks want to show up and chit-chat, that we can have a discussion about MS. Ask me anything. So I see that Christy's online. Hey, how are you? Thank you for jumping on. Ben is here from Owasso. Oh, that's awesome. As you come online, share with me where you're coming in from. Tell me where you're logging in from, because it's super fun to see people from around the globe in this global village. Becky Winters, hello to you. Cindy, it is great to see you. We've got Bevsky here from Ontario. Howdy, howdy. Jennifer Smith. Shannon is on the line. This is awesome. Julie S. is joining us from the UK. There's Valerie who is here. We've got Serena. This is fantastic, guys. I've got a bottle of water. You probably noticed that my environment is a little different. I'm actually at my office today. I wanted to change the scenery, and I get to look at the Ohio forest, looking out the window here. And so that's super, super fun for me. Look at all these great folks that are jumping online. Erica is here from Arizona and Dominic from Istanbul. This is really great. Camelia is here, says, can I get well? I have many symptoms, diagnosed since the age of 19 in 2012. Yes, you can get well. And today we're going to be taking questions about MS and, in fact, how you can live your best life despite having MS. If you guys are excited to engage in an Ask Me Anything conversation, throw a like. Make sure that you give a like to the live stream. It actually helps me in the channel quite a bit. Look at this. As you log on, make sure that you're sharing where you're coming from. I love to go back through the live stream afterwards and look at this growing global online community. Also, rules of engagement. This is a friendly place where we do kind and nice exchanges. So please leave your heckling alone and leave that kind of stuff to a different channel or a different live stream chat. Also here, I can't answer your questions for your specific situation. I can't see you. I can't examine you. I don't know the full story. So I can't answer individual questions for you, but I can answer more general questions. And so it's my hope that you can phrase your questions in a way that way everyone can benefit. So with that, if you guys are ready for an Ask Me Anything, throw some fire emojis in the chat. Go ahead and light up the chat with fire emojis. Once we get the whole chat lit up with fire emojis, we'll start taking the very first question. Jen from Maryland is on. Yeah, Steve from Bowling Green, Ohio. Steve, how are you? There's some, so Christy's got the idea. Yeah, go ahead and light that up with fire emojis. Let's get the whole chat thing filled up with fire emojis. And then I know that you guys will be ready. So I've got Erica on board. I've got Emma on board. I've got Teresa, this is fantastic. Tony's lighting it up. Chris is lighting it up. Okay, guys, I think it's about time. Amy Welsh is in the house. What's up, Amy? I hope that you are doing well. We are ready to rock and roll. All right, thank you for that. Let's take the first question. Now, go ahead and type your question in the chat. I will do my very best to take them in order. Matt is on the line. Matt's one of our awesome moderators. Matt, it's good to see you, my friend. Thank you for being here. Marilyn's going to kick off the first question. So let's see here. After the 2 COVID-19 vaccines, do you think we will need a booster vaccine? So that's a very timely question. Now, Marilyn, I don't know the answer. If I was guessing, my concern is that COVID-19 may go from a pandemic to endemic. And when something's endemic, it means that it's going to stick around. Like influenza, the flu is endemic. And so we have a annual booster or new type of vaccine each year trying to do our best to fight off flu. And I think that may become a reality with COVID, although we don't know yet. I also think that there's some value potentially in giving boosters to patients who are immunosuppressed to push up their chance for immunity. Good question. All right, let's see what other questions we have. Tom writes in, has Lemtrada worked for anybody? So he goes on to write that his wife switched from Tysabri to Lemtrada 5 years ago and went from walking to being in a wheelchair to homebound. So Tom, I actually can answer that question. So I'm an MS neurologist who's used a tremendous amount of Lemtrada in my practice with patients that have had breakthrough disease. So I can say with some authority that yes, many people have done very, very well on Lemtrada. Now, very clearly, that was not the experience of your family, and my heart goes out to you. And I'm sorry to hear that she's done so poorly. Not every drug fits every patient. And sometimes things happen despite the very best of intentions in drugs. That doesn't make it hurt any less. And Tom, thank you for jumping on. So let's look for a question. We've got Mercy Russell, who writes, I have a bad case of vertigo. Would this be associated with MS? So yes, it can. So the centers for vertigo are in the base of the brain, in the medulla, and they're actually wired to your ears. The most common form of vertigo, however, is not from multiple sclerosis. It's actually from a different process called benign paroxysmal positional vertigo, so BPPV. And that's the most common reason that a human being, feels like they have vertigo, and including a human being with MS. Now, let's back up and unpack this a little bit. Vertigo is a hallucination of movement. So you're specifically hallucinating that you're spinning in a circle like this, or spinning the other way. That's what we neurologists define for vertigo. Vertigo from MS would be damage to the medulla, so the actual structure in the brain, and that can unfortunately happen. The more common reason that someone has vertigo, including someone with MS, however, is coming from a problem in the inner ear, this BPPV. And if you have vertigo, sometimes by listening to the story, you can sort out which one's which. BPPV, benign paroxysmal positional vertigo, is triggered by quick head movements. So you turn your head and then you feel like you're spinning. And there's a burst of vertigo and then it dies down over about 30 seconds. And that story is very different from what we typically hear in the setting of MS vertigo, which can go on for hours or days and days. Good question. All right, what else do we have going on here? If I don't get to your question, gosh, I'm so bad at managing these. And it's my hope if the moderators feel up to it, they can throw up some questions for me to look at. Karen Tweed writes, question, can perimenopause hot flashes trigger MS symptoms? Yes. And in fact, anytime there are fluctuations in hormones, like menopause or menarche at the onset of each menstrual cycle, or during pregnancy, or during delivery, or even during breastfeeding, at all of these moments, there's changes in hormones, and you can see a change in MS disease activity. And it's actually been studied that the onset of menopause, there can be an uptick of MS symptoms in some women with MS. And if you're having hot flashes, that may trigger some heat-sensitive symptoms. I've heard that in patients as well. Excellent question. So Heather writes, is there any information that you can share regarding women who either get MS or a relapse postpartum? There is. So there's a very famous man named Confabreau, who's a French gentleman that recently passed away in the last, I think, 5 or 10 years. And he did a very pivotal trial, a very important clinical research trial looking at women with MS who are pregnant. And he followed a bunch of them over all their pregnancies. And he was able to describe them in an article, or in a research article called the PRIMS trial. And what he wrote about has held true. What he found was if going into pregnancy in the first trimester, the risk of an MS attack is about the same as it was before you were pregnant. And then during the second trimester, the risk of an attack goes down lower. And in the third trimester, it actually goes really low. And then in what I call the fourth trimester, so the 3 months after you deliver the baby, it goes up, higher than normal. And if you look across a year, it's a wash. Now, every individual human, therefore every individual woman, is different. And so it doesn't guarantee that that's what's going to happen during pregnancy, but that is what he saw. And that's definitely what I've seen. To speak more plainly, most women during pregnancy have a really quiet time of it. And there's a cool reason for that, really. So when you become pregnant, half the genetic makeup of the fetus is yours and half is your partner's. And that's foreign DNA. And under normal circumstances, your immune system does not like foreign DNA. And so it would try to kill it, except that would defeat the purpose of the pregnancy. So your body has come up with a way of protecting the fetus against your own immune system, and that's estrogen. So when you're pregnant the placenta pumps out estriol, which is a sex hormone, estrogen, really, really high levels, like insanely high levels. And those super high levels of estriol protect the fetus against your immune system. They create what's called an immunoprotective state. And it's not just protective for the fetus, it's also protective for the rest of the body. And that's why we think we see a decreased risk of autoimmune activity during particularly the second and third trimester. Now, when you deliver the child, you then deliver the placenta, and then your estriol levels go back down to normal rates, from superhuman to normal, and there's a potential rebound. Now, I say potential. Most women do not have a rebound after delivery. Some do. And we can treat those the same way that we would treat an attack. In fact, let's talk about treating an attack during pregnancy. In my personal experience, which now is like a decade and a half or maybe a little more, of helping families impacted by MS, I've had really good experiences with pregnancies. MS doesn't interfere with the ability to become pregnant or gestate, and it doesn't interfere with your ability to deliver. You are able to have a epidural, so yes to epidural. There's some really old school anesthesiologists that still think that it might be a risk, but that's been disproven, so you can have one. And if there's an attack during the first trimester, we try really, really hard not to give steroids, because during the first trimester, you're literally building the organs, organogenesis. And so if you gave steroids, it would mess that up. However, after the first trimester, the fetus's parts are all built. And from the second and third trimester, you're just growing them, making them bigger. And so giving steroids doesn't harm the fetus in the same way. And in my clinical experience, I have had women with MS who become pregnant and then unfortunately have an attack or the second, third trimester. I call the OB-GYN, and we've always had the same conversation. Hey, this is Aaron. Here's what's going on. The OB-GYN says, go ahead and give him steroids. It's okay. I've never had a different response. And I think that obstetrician gynecologists are very comfortable with those risk profiles. And fortunately, we've had some really good outcomes. So that was a great question. There's maybe another whole part to this pregnancy thing about disease modification during pregnancy, and I'll leave that for a different discussion. Okay, at this, I'm sure that I've lost a lot of questions here. Let's see. Anne Marie writes, could neck pain be associated with inflammation from MS? It could be, but not the way that most people think. Most people think, well, if I have a lesion in my neck will hurt. And that's not really the way it works out exactly. So yes, it can cause pain, but it's typically referred pain. Pain coming from the central compartment, brain or spinal cord, is typically hard to describe. It's because we're not wired to be able to report damage to, say, the spinal cord. We are wired to report damage, like to, say, the surface of your skin. And so oftentimes the description of pain in the setting of MS is vague and hard to describe. What are your thoughts on hematopoietic stem cell transplantation, HSCT? So my thoughts are that it's a procedure, not a medicine. My thoughts are that the research has been building, and my thoughts are that it's becoming increasingly exciting. I do not feel that stem cell transplantation is prime time yet. I do believe that it's fantastic that we're testing it, and that I think that it probably will become prime time in the next 10 years. I do not recommend that people do stem cell tourism. I actually strongly am opposed to stem cell tourism, just because of the risk associated with that. I could talk about that for a bit, but I do think that in the context of an appropriate clinical trial, it's a very exciting option. I also think that it's very risky, and there's lots and lots of considerations. And so sometimes I'll hear a patient say, I don't want that medicine because I don't like the risk, but I do want a stem cell transplant. And that lets me know that they really don't understand the extent of what's involved in stem cell transplantation. So great question. Thank you for asking it. So let's see here. What's your take on administering Rituxan? I love Rituxan. Rituxan is an anti-CD20 chimeric monoclonal antibody. So in English, it's an IV medicine taken in the vein, taken twice a year typically, and it's highly effective to treat MS. Rituxan is one of several B-cell depleters, and it's a class of medicine that's very effective in MS. Ocrelizumab is FDA approved. Rituxan actually is not FDA approved. Kesimpta is a B-cell depleter, which is actually a sub-Q injection. And so we're going to see other B-cell depleters join the market. Ublituximab will soon join the market. And these are really effective medicines to treat MS. Let's see. Heather writes, "Hi, Dr. Boster from Fort Worth, Texas. Hello. Oh, love your videos. Thank you." Well, thank you very much. I really appreciate you saying that. Let's see here. Daniel writes, "Hi, Dr. B. Could you talk about the presentation of trigeminal neuralgia?" Yes. So there are 12 cranial nerves that basically run the face. And the trigeminal nerve is the fifth cranial nerve, right? So it's like a V for the fifth cranial nerve, and it's responsible for facial sensation. There are 3 branches, and so there's a branch up here, all right, that covers the surface of this area of your head, and it kind of can even come down to involve the eye, and that's called the ophthalmic branch, or the first division. There's a second branch along here, and that's called the maxillary branch, or the second division, first, second. And then down here is the mandibular branch, or the third division. So we would say V1, V2, V3. That's the way that we describe the layout of the trigeminal nerve. Now, if the trigeminal nerve is damaged somehow, it can send a fake pain message to your brain telling you that you have pain here, here, or here, depending on where the damage is, even though nothing bad is actually happening. And it's described as some of the most severe pain that a human being can experience. It's been the cause of suicide because the pain is so severe. And peripheral nerve-wise, the most common way that there's a problem is that where the nerve leaves your brain and comes out of the skull, so it leaves the inside of the skull, comes to the outside of the skull through a hole. That's called an os. So you can imagine that the nerve is coursing through that space, right? And if it becomes pinched, it can pinch that nerve, and that can cause damage. Then you can open that up neurosurgically. People with MS are 14 times more likely to have trigeminal neuralgia. And it's because in addition to that, they could also have damage to the actual nucleus, so the motor that runs that nerve, which is in the brain. So damage to that portion of the brain can then also cause trigeminal neuralgia. Now, trigeminal neuralgia is nasty, and it can be really hard to treat. And we don't use narcotics. That would be a huge error, because this is a chronic pain. In some cases, it's a very severe pain. We like to use neuropathic pain medicines. In my mind, they work better. So neuropathic pain medicines are medicines that were originally invented for typically other purposes. And we've realized that they work really well to treat pain coming from spinal cord, brain, nerves, etc. So there's typically 2 groups. There's medications that were invented to treat seizures, right? So seizure medicines, and medicines that were originally invented to treat depression. And we've determined over time that they actually also help with pain. So if we talk about anti-seizure medicines, these are medicines that stabilize cell membranes so that they don't fire electrically inappropriately, because a seizure is like an electrical storm on the brain. And so when you take a seizure medicine, you quell those neurons and get them to calm down. Well, when you have the trigeminal nerve misfiring inappropriately, it's really a similar problem. And so you can use the same medicines to quell them, to get them to calm down. In the world of antidepressants, you're also finding some of them can be very, very effective in treating trigeminal nerve pain. And sometimes we have to use multiple medicines in order to quell the pain. There are other modalities that can be very helpful, and your friendly neighborhood neurosurgeon or pain doctor can do ablations to the nerve, or they can do gamma knife. They can go in and open up that space. There are neurosurgical procedures or pain procedures that have been, life-saving essentially for some of my patients. Now, unfortunately, in the setting of MS, there's a chance that this can come back. And so it's unfortunately not uncommon that we have to treat maybe with multiple medicines, and there'll be periods of time where we can kind of go down on the dose and we do okay. And then sometimes we have to ramp back up, and such is life. I'll also share that I have found that trigeminal neuralgia pain seems to respond really well to cannabis. And so several of my MS patients that have trigeminal neuralgia have found that they can use cannabis in a couple different ways to really help with the pain. One particular story that I'll share, a gentleman who's very affected by MS and can't move his arms and his legs very easily. is in a wheelchair. When he has trigeminal neuralgia, his face hurts so bad that he can't really move his mouth and lips. Like, so he couldn't use like a vape pen or something because the pressure around his mouth would be excruciating, which is terrible. And he can't really swallow a pill very easily. And so what his family does to help him is they pull up a tincture, which is a liquid of THC and CBD, of cannabinoids, and they drip it under his tongue. And there's big blood vessels there, and it's absorbed into his bloodstream very quickly. And it actually has, on several occasions, broken the trigeminal neuralgia pain, which is really, really cool. So trigeminal neuralgia is something that we have to take very seriously because the pain can be quite severe. Excellent question. I can't believe it. There's 174 people that have jumped online on a Sunday afternoon. That's really, really awesome. Thank you, everybody. If you like this live stream, please give it a thumbs up. You can swipe and give it a thumbs up or what have you. And it just helps me know that you're liking what's going on. There's 55 thumbs up. If everybody gave a thumbs up, we might be able to get that up closer to 100. That would be really cool. So let's take some more questions. So Bresky writes, tips for people with MS who don't want to stop taking long backcountry and physical demanding trips like canoe trips, hiking trips, etc., that are far from society or service in general. So that's an awesome goal. And I think every person who is listening right now should be able to share some life goals. And so that's a really important life goal. What I'm hearing here is that Bresky wants to continue outdoor activities, strenuous outdoor activities, going out into the bush. And if that's a life goal, in my mind, it's our duty to help you achieve that life goal. And so I actually have some videos on this channel talking about preparing for vacations or an MS toolkit if you're going out for a day trek, But I think that there is still a path that you could go out and do some bushcrafting or canoe trips. And one of the things is you want to make sure that getting ready to do it, that you're in really good physical condition. So spending months preparing your body, making sure that you are physically capable of doing that kind of thing, maybe doing small trips to work up to it. You don't want to go from couch potato to 20-mile canoe ride or what have you. The second thing is you want to be very thoughtful about the location where you are. Make sure that you know what the weather's going to be like. If you're particularly heat sensitive and it's super freaking hot, maybe that's not the best trip option. Maybe there's another option where the temperatures are more reasonable, or maybe you're going to have to arrange the time of travel to certain times during the day. Similarly, if it's really, really cold and you have, for example, really bad spasticity in the cold, we have to think about that and plan accordingly. And so I think that there's a lot of prep work that one can do. As far as taking medicines, a lot of that can be planned out. And so if you take symptomatic medicines, making sure that you bring them with you and that you bring enough, making sure that you bring extra, God forbid a pack is lost or what have you. And then there's always the question of if there's an attack. And so I don't want you to live in fear and give up traveling in case there's a hypothetical attack with a leg that gets weak. Because statistically, that's very unlikely to happen. And unless you're going completely solo for longer than a couple weeks, I hope that there's a reasonable way of thinking, okay, my mates can help me do X or Y. And something that might be reasonable in talking to your MS neurologist is to travel with 125 tablets of 50 milligram prednisone. That's enough medicine that you can do the bioequivalence of an IV bag of Solumedrol for 5 days in a row. And so under an extreme circumstance, you could actually initiate treatment for an attack. Now, you would have to have a really strong relationship with your MS neurologist and work out the details. Similarly, and I've done that before with some patients. Similarly, if you're prone to urinary tract infections, you may go on the trip with a package of antibiotics just in case. So I think there's a lot of things that can be done to prepare. I think if that's a goal, then you should embrace that goal. And I hope that you do. Very good question. Now, we've got the MS Water Challenge going here. For those of you that are not familiar, I drink and you drink. Come on, let's drink up and up our water game. And there's 190 people that have jumped on. Thank you, thank you. There's 105 thumbs up. That's really, really awesome. This is so fun for me, and I want to thank you guys for participating. So Daniel writes in, hi, Dr. Boster. Hello, Daniel. I'm in Germany, and last year I was diagnosed with MS. What are your thoughts about hit hard and early strategy? So Daniel, I believe in that very, very strongly. I have a tremendous amount of content on the channel where I talk about my philosophy on applying disease-modifying therapies. So if you go to the YouTube channel, there's a playlist called Treatment Philosophy. And I have several different videos there. One is called Sins of Our Fathers, where I talk about why older neurologists have not embraced highly effective new therapies. And I explain the reasons behind that. And I explain about how sort of the academic Ponzi scheme of sorts propagates these misunderstandings from mentor to mentee. And I talk about that in there. I also talk about how the escalation model itself is really flawed. I talk about therapeutic inertia and how step edits and insurance in the United States, how pressures from doctors and patients can lead to people not using therapies appropriately. So you touched on a very important topic to me. It's my opinion. I want to put you on the most effective therapy that you're comfortable taking. And that's a very, that's a sentence that I constructed on purpose, all right? So I meant what I said. The most effective therapy that you're comfortable taking. Because you're the human that has to receive the therapy, right? And just because I think this would be a really good, efficacious drug doesn't mean you want to put up with the side effects or that you can tolerate it or that you accept the risk. And so you have to be on board. And if the most effective option is not something that you accept, okay, then we're going to downgrade to something that arguably might be less effective, but might be a better fit for you at that time. Thanks for asking the question. I appreciate you sharing with us. So let's see, Jane writes, in the USA using Mayzent, or is the USA using Mayzent? I'm on a trial now. I have secondary progressive MS. So yes, Jane, Mayzent, which is siponimod, which is a second generation S1P1 receptor, like in the Gilenya family, is FDA approved for relapsing forms of MS in the United States. It's approved for CIS, relapsing MS, and secondary progressive MS with attacks. And it's a Gilenya Me Too drug. So it's very similar in my mind to the parent compound Gilenya. Next question. Daniel writes in, hi, Dr. Boster. Hey, Daniel. Oh, I already read that question. I'm so sorry. All right, let's go lower. Valerie writes, I do yoga, Pilates, strength, balance work. Overall, my MS is doing just okay. I was on Copaxone, now on Kesimpta. Any suggestions to help keep me going? Foot drop has been acting up. So Valerie, thank you for writing in, and you're doing a lot of really hard work. You know, I want to talk about being 5 for 5 because I'm hearing a lot of 5 for 5 there. So 5 for 5 is the 5 things I want you to do to live your best life despite having MS. Number 1 is to take an MS medicine and make sure it's working. And in specific, take the most effective medicine you're comfortable with. And here you've upgraded from Copaxone to Kesimpta, which is an upgrade considerably in efficacy. So I'm digging that. Now we just need to make sure that you're responding to the Kesimpta. So moving forward, having neurological examinations and meetings with the neurologist and MRIs and all that kind of good stuff. That's the first one. The second one is exercise as part of your lifestyle. And I hear that you're doing that. Yoga and Pilates and balancing and strengthening. And I hope that you're working on that foot drop. And so I think you've got that locked in. There's a couple other things that I think that we should think about. One of them is supplementing vitamin D and eating a whole food, real food diet, avoiding fake foods and foods with chemicals and names that you can't pronounce, and fried foods and heavily processed foods and fast food and soda. That can make a really big difference. What else do we have? We don't want to smoke things. All right. So we don't want to take carbon-based matter and light it on fire and suck in the smoke, whether that be tobacco or cannabis. And lastly is a daily exercise of mindfulness or stress relief, meditation or something like that. In fact, you may be hitting some of that with your yoga. So I really think you're on the road to Wellville. I'm very impressed with what you're sharing. You got to keep on keeping on. All right, let's keep going with other questions. That was a great one. And here we have Vineeth, who's writing from India. Howdy, howdy. I've also recently feeling like something is always falling off my right eye. But when I check, there's nothing there. Is this MS or dirt is actually falling always in my right eye? So yes, MS can give you phantom symptoms. So sometimes people can feel like their arm is on fire, or that there's a band around this arm, or they can feel like there's a cobweb, or they could feel like something's falling off their eye. And it's super, super annoying. And what's happening is actually the skin is normal. And then, but the problem is in the brain, they're interpreting that something's happening. So your brain is is being told something that's not actually true. Something's on your face when it's not. That's a very unpleasant symptom. So Shannon writes in, went all last year with numbness and tingling, finally was taken seriously and in December diagnosed. Started Ocrevus in March and still symptoms. Sometimes when I bend over and look up, I see stars. So Shannon, you were diagnosed at a really rough time with a global viral pandemic, when there were entire hospital systems that were diverting all energies towards COVID wards to try to save lives. But we know that people with chronic conditions didn't get the optimum level of care all the time. And we know that, in fact, there were delays in cancer diagnoses and delays here in your example of an MS diagnosis. And I'm sorry for that. That super stinks. I am glad to hear that you're taking a highly effective medicine, Ocrevus. And I'd submit to you that it's not long enough yet to really dial everything in. I just talked about being 5 for 5. And so you want to make sure that you're 5 for 5. And you want to work with your MS neurologist to knock down chronic symptoms. So taking a pill for that ill, whether that be depression or bladder or spasticity or neuropathic pain, so that you can live your best life despite having MS. So we've got 198 people that are on. That's amazingly cool. Thank you. MS Water Challenge. Let's keep doing some questions, guys. So Clowny777 writes, Viagra for women. Do you recommend? Study says that after 8 days, MS symptoms are better. So I'll share with you that I have prescribed Viagra for women who are having difficulties with lubrication and sexual sensation. And I haven't had amazing results. There is a drug called ADDI, ADDII, that I do prescribe for low libido in women with MS. Now, I'm not aware of this study. Here you're saying that there was a study that suggested that some MS symptoms got better. So if that's a trial that's recent, I'm not familiar with it. I'll have to look it up in PubMed. Maria writes, is rituximab as good of a treatment for dually diagnosed MS and RA? And the answer is, yeah, I love doing that. So I have patients that have more than one autoimmune condition. I have several patients that have MS and rheumatoid arthritis, and we use Rituxan in those instances, and it tends to work really, really well. It's great to get a twofer. There's another medicine where you can get a twofer in arthritis, and that's using Arava, and the first metabolite Arava is Aubagio. So you can use either one of those products in someone that has MS and RA, and it would cover both as well. So that's another helpful double benefit, if you will. So Steve writes in, can an anti-inflammatory diet help with MS symptoms? So Steve, I've had patients tell me yes, and I've had patients tell me no. And I think that it's worth trying. The good news is that in about a month or two, you could find out. Am I able to tell you that absolutely an anti-inflammatory diet is going to slow the disease, et cetera? No. Do I think that a healthy diet can make a really big difference in symptoms? Yes, 100% I do. Great question. Millie Mack writes in, if you on a DMT, do you still experience symptoms? And if so, why? Yes, that's a great question. Oh, and the question's just like jumped. So I wonder if I lost that question. So a symptom is something that you experience. So if you, let's take an example of burning when you urinate and a foul smelling urine and a sense of fullness in your bladder. So those are symptoms that you experience. And based on those symptoms and based on some laboratories, we might diagnose that those symptoms were caused by the diagnosis of urinary tract infection. Now, when you have a neurological symptom, you don't know what it's coming from. Is it a new attack? Or is it old neurological damage where that function of the brain is short-circuiting? And you don't know which one it is necessarily. You just experience a symptom. So if you've had prior neurological damage, under certain circumstances, it can kind of come back out. Let me use an example of optic neuritis of the left eye. So God forbid, years ago, you have optic neuritis of the left eye and you go blind and it hurts when you move your eye and you get steroids and over time it gets better and you can pretty much see normally. But if you're under tremendous stress at work, it might short circuit and you may have, again, some of those symptoms. Or if you have an infection, or if you have a fever for another reason, or if you have stayed up and missed sleep. Under any of these circumstances, if you're overheated because you're in Australia and it's freaking hot outside, In any of these circumstances, this can short circuit, and it's called a pseudo attack. It's the reemergence of an old symptom, but it's not caused by new damage. Also, you can have progression of neurological disability, where there's a slow, steady loss of function, slow meaning like over months to years, not days to weeks or something like that. And that can happen independent from new disease activity, like on the MRI or an attack. I have several videos where I talk about progression in MS, where I kind of touch on this. The leaky pool model is something that can be very helpful to kind of explain this. We have 205 people on. That's really, really cool. Guys, there's so many Village members on right now. Let me ask you in the chat, share with me what kind of content you would like to see from me. Many of you, these are names that I've known for a long time. I've seen you, and you've been a member of this Village, a community member for years in some cases. And I've tried all kinds of different formats over the years. I've been doing a video every Monday morning for some time now, and I plan to continue to do a video every Monday morning. And I would love to know what you would like to hear about. Over the next couple months, I have videos that are planned and they're set to launch. Most of them are teaching you about MS clinical trials and clinical research, sharing specifics about, for example, like what is randomization or what is blinding, or why is the trial constructed the way it is. And then I've also done a lot of Q&As where I've gone back through the comments section of this channel, and I've pulled out questions and I've answered bunches of them. So that's what's in store over the next 2 months at least. But I would love to hear what you guys want to hear about. I've done earlier this year, I did a lot of stuff on COVID. I want to get back to talking more about MS. I've done some stuff on vaccines. I've done some stuff where I've showed you MRIs. So I would just really love to hear kind of what you think. Now, Matt's helping me out. Matt, I finally caught up with you here. So I'm sorry, I was way scrolled up forward. Matt's reposting some really good questions. And so this is a question from John. Hi, Dr. Boster. I'm on Zeposia, considering changing to Mavenclad or Kesimpta for a higher efficacy and fewer lifestyle limitations. How would you guide a patient through that transition? That's a really nice question. So Zeposia is a Gilenya Me2 drug as well. So it's an S1P1 receptor modulator. It's a pill that you take. And here, John's talking about going from Zeposia to Mavenclad or to Kesimpta. And I would share that that's not that hard of a change to make. Let me explain why. Gilenya sticks around in the body for a while. So if you've been on Gilenya, which is the first S1P receptor, and you stop it, it's going to take a couple months before the Gilenya effects wear off and the cells leave your lymph nodes and go back out into the bloodstream. In the setting of Gilenya, when you switch drugs, there's a question mark about, do you need to let all the cells come back out so that those other therapies can get to them? Now, with Zeposia, the on-off is a bit faster. And so if you've been off, you can be off for a shorter period of time, and then your cells are going to come back out of your lymph nodes. And so I think the transition would actually be pretty straightforward. And we may talk about specifics, but even just stopping it in a month later, starting that next drug might be something. Now, the good news is, instead of guessing, you can actually check a white blood cell count with differential, and it'll give you the information that you need to counsel the human. So as opposed to just saying, well, let's think about it in a month, we could check blood work at 2 weeks and 1 month, and with a much better sense of understanding, say, okay, now's the time. So I don't think that would be a tough one. So another question that Matt was kind enough to queue up. And guys, thank you, Matt. I really do appreciate all your help. I want to call out a fantastic moderator. He's queued up a question from Heather Smith. What are the reasons for getting a clear MRI back? My neurologist only reason we will see with MRI patients or with MS patients. Is there more to this, or am I just going to get rid of MS? So I don't completely understand your question, but I think what you're saying is that the MRI has no spots. And if the MRI has no spots, if you have no lesions in the brain or cervical, thoracic, spine, I'm going to call into question the diagnosis because particularly with proper neuroimaging in the modern era, it would be very, very hard, if not impossible, to have confirmed MS without the presence of lesions. So, but I'm not sure that I actually understand the question. And so if I missed it, then I apologize. Matt's queued up another question from Paspalum, I'm sure I butchered that name, I'm sorry. Any development on myelin repair medicine? Yes, so there are several trials that are ongoing. I don't have readouts. We've had some disappointments recent with remyelinating options, but there are still several trials that are ongoing. We should be getting readouts at congresses over the next couple years. So Marius writes, what can I do during my transition Aubagio corona vaccine to Ocrevus to prevent relapses? All right, so what I think I'm reading is you're going from Aubagio to Ocrevus. And what I think I'm reading is you want to get a COVID vaccine in there. So I'll give you my opinion, all right? Now you have to talk to your neurologist about what's right for you. Aubagio won't interfere with mounting a vaccine response. So I'd take Aubagio and I'd get vaccinated. And then when the amount of time necessary to let the vaccine take, which would be like 2 weeks after the last shot, if it's a 2-step shot, maybe a month after the shot, if it's only 1 shot, then I would stop Aubagio and I would start your next medicine. And that's how I would do it. I wouldn't wash the Aubagio out. I think that takes too long and is not worth the potential benefit. And that's how I make the transition. I don't think that would be a hard transition at all. So what else do we have? Daniel Barman writes, hi, Dr. Boster. What are your thoughts about the treat to target strategy? So treat to target is a rational doctor's approach to something. So for example, when managing blood pressure, you treat to a target of a certain blood pressure numbers, and you treat to no end organ damage. So having a target to treat towards an MS, I think is a great idea. I think it helps keep us focused. I think it helps keep us honest. It helps keep us transparent. So I think treating to a target is a really good idea. Absolutely. So let's look for another question that Matt's queued up. Chrissy D413 Matt writes, please, B12 being low, is there a link to MS? No, there's not a link to MS, but you can have a low B12. And so fortunately, there's lots of ways to supplement B12. You can buy B12 over the counter as a pill. Some people have impaired guts and they don't absorb the B12, and then you can actually get B12 injections. You can test B12 pretty simply by getting a blood test, and so we can adjust the levels accordingly. Good question. So let's see, Ricky H, my wife has NMO. Do you have any professional opinion or referrals for specialists on this? So I'm an NMO doctor. I see patients with NMO, and I use the 3 FDA approved and the Rituxan FDA not approved therapy to treat NMO. I also manage NMO symptoms. I have several patients with NMO that have pretty bad spasticity. So I'm an example. And a lot of so-called MS neurologists also manage NMO because they're similar conditions. They're both CNS inflammatory conditions. They both involve the immune response, and some of the therapies overlap. So depending on where you are in the world, finding an MS center, you're going to probably be able to find one of the MS experts, if not several of them at that center, that understand and manage NMO. June Stephenson writes in, suggestions with regards to combination of pain medicines. Example, MS medicines, bronchial plexus due to a lesion of the spine, etc. I have SPMS in the UK, so not taking other treatments. So pain, as you point out, can be from multiple different sources. And so we have to try to pick apart the different components and then apply therapies that are appropriate for those components. So pain from MS is presumably coming from one of a couple places, either damage to the brain, optic nerve, spinal cord, causing a misfiring and a miscommunication of sensory information, causing pain. You can have spasticity-related pain from spasms and cramps. You can have MS hug. You can have Lermite's phenomenon. There's a bunch of pain. In fact, I have an entire playlist on pain and MS. And interestingly, most of those are treated with very similar medicines. So neuropathic pain medicines, like I described earlier in this live stream, most of those are all responsive to those classes of medicines. Now, you can also have nature be a little too generous, and you can have a peripheral problem. You describe a brachial plexus injury. Interestingly, the same medicines that treat neuropathic pain for MS will also work for the brachial plexus. Now, you could have other pain problems like musculoskeletal or joint problems. And so we have to think globally and comprehensively about the human being to make sure that we're addressing the different kinds of pain. Typically, I'll go after one kind and try to improve that as much as I can to see where we end up, and then I'll go on to the next kind of pain. So Jillian asks, hi, Dr. Boster, does the AstraZeneca vaccine provide enough protection against COVID-19 when taking Mavenclad? Also, what's your experience with Mavenclad causing weight gain? So I don't know the answer. I've not used the AstraZeneca vaccine. It's not available where I practice medicine, to my knowledge. I haven't had any patients take it. So I haven't read any papers specifically about AstraZeneca in Mavenclad. So I don't know that answer. Now, what I do know is with the Pfizer vaccine, when you gave someone with MS the Pfizer vaccine who was on Mavenclad, it didn't matter when you vaccinated them in relation to their Mavenclad. Interestingly, at least in this one paper by Akron, it didn't make a lick of difference. And if you had just taken Mavenclad or taken it, months and months ago, or whether it was the first year or the second year, you mounted an immune response. So that's very encouraging. I don't know why that would be dramatically different for AstraZeneca, but again, I don't know. Now, the second part of the question is any experience with Mavenclad causing weight gain, and I have not seen that in the patients that I've treated to date. It doesn't mean that it's not a thing, but I'm not aware of that, at least in my own clinic. Hey, check this out. So Brandon Bieber is online. Matt was nice enough to forward that to me. Brandon, how are you, my friend? Dr. Bieber is a fantastic MS neurologist. He works for Kaiser Permanente in California, in Los Angeles area. And he has a superb MS YouTube channel. So if you don't currently follow Dr. Brandon Bieber, you must do that. Just type his name into YouTube. You'll find his channel. The guy's pretty awesome. He's written a book about resilience in MS. He puts out videos every Wednesday. I love the guy. And so you definitely should totally check him out. And so Dr. Bieber, thanks for being here. I appreciate your support, man. So Bree at Matt writes, he can be, well, I don't understand that question. I'm sorry. All right. So here's a question from Bad Bobby. That's a fun name, Bad Bobby. I have developed multiple chemical sensitivities. Specifically, I react to chemicals in laundry detergent, fabric softener, deodorant, perfume. Is this MS-related short circuit brain? I don't know. I have not seen that in my patients. And so I'm not really sure. And I would probably start by talking to an allergist, immunologist, or your primary care doctor and work backwards from there. I don't think there's a clear or easy association with MS. All right. Reading some questions here. So Calico45 writes, hey, doc, help. What do you suggest for short-term memory? So people impacted by MS can have difficulties with thinking and memory. I have an entire playlist on this channel with, 30 plus 40 videos on cognition in MS. Please check out that playlist. I've got videos packed full of tricks and tips to help up your cognitive game. And there's a lot of work that we do. It's typically a multi-pronged approach where we take medicines into play, removing naughty medicines and adding medicines to help attention, and working on depression and anxiety and mood and getting physically active and fit. And there's a lot that goes into managing cognition. So check out those videos, and I hope you find them helpful. We Are Venom writes, I'm a 34-year-old male with an EDSS of 1.5 after about 15 years. I just got on Ocrevus. I was told I have a heavy burden of disease. Should I expect to get worse? So that's a lot of information, but I don't have enough information really to make sense of it. So first of all, stating that you're 34 with MS for 15 years, which means pediatric onset MS. And so pediatric onset MS, folks get disabled slower, but they can end up disabled at a younger age because they started younger. And so that's one factor. The second one is the EDSS of 1.5 is very low. So that's fantastic. To have MS for 15 years with a low EDSS is a very good prognostic factor. But a third of people with that category are going to go on to have active disease. Moreover, we now hear that the MRI of the brain has a heavy burden of disease, which means lots of spots, and that is a bad prognostic factor. So I don't have more information to help guide us in trying to understand the question. But I do think that it's a really good thing that you're on a disease-modifying therapy, and I particularly think Ocrevus is fantastic because of its ability to slow progression. So if you're at increased risk, and the brain MRI you may be, and the early onset of diagnosis you may be, being on a highly effective DMT, I think, is the right thing to do. And then, of course, we want to be the rest of 5 for 5. Daily mindfulness and meditation, along with that DMT, along with not smoking stuff and paying attention to diet, exercising as part of your lifestyle. I think I left one out. Exercise, smoking, good job, Aaron. Vitamin D, take a DMT, and meditate. All right, so what else do I see here today? Liam writes in, would love to see behind the scenes of your MS Center video. I'd love to do that. I could show you around the MS Center. I'm going to have to be thoughtful and get a handheld or something, because right now I'm on my work computer. But we could definitely do that. Let's see. Looking for other questions. Sharon Rings writes, I was officially diagnosed Thursday by you. How do I know if I'm an active relapse? Because everything is all very new. And so whether you were diagnosed by me or by somebody else, a new diagnosis is a period of time when things are really fresh and new and kind of scary sometimes. And so one potential helpful tool that I like to go over with people early on is the 24-hour rule. If you have a new neurological symptom lasting longer than a day, 24 hours, you got to call your neurologist, whoever that neurologist may be. If you have a symptom that lasts less than 24 hours, it's less likely to be a new MS thing. And so using the 24-hour rule will help you not get overly anxious, because whenever you're given the diagnosis of a chronic condition, any chronic condition, diabetes, cancer, rheumatoid arthritis, what have you, you're going to start to interpret your own body's sensations and happenings with a critical light. And so, for example, if you wake up and your nose itches, you're going to ask a rational question. Is the nose itching related to the new diagnosis? And that can drive you a little bit bonkers with concern and anxiety. So use the 24-hour rule. It's a good guide. If you wake up and your nose is itching, you can say, well, wait, it's only been itching for like 30 seconds. So it's not been a day yet. So I can be less concerned. Now, on the flip side, if something's gone on for longer than a day, don't be stoic. Call your neurologist and we can talk about it. All right. Bree at Matt writes, what precautions should people take with the COVID Delta variant if they're on Ocrevus? So I think that people who live on Earth should do two things related to COVID for protection. That's people on Earth. So all people on Earth, including people with MS and including people without MS. I think that you should get vaccinated, and I think that you should wear a mask in public. And so this is the mask that I'm using today. And when I'm not in my house, I'm wearing it. I wear it outside of my house. Now, I'm not personally immunosuppressed and I am vaccinated, but this is an extra protection. And if the Delta variant or whatever variant might not be as amenable to the vaccine that I have, this is going to help a lot. And so those are the two things that I think that we should absolutely do. There's 159 thumbs up. That's amazing. Thank you. If you're digging what we're doing today and you haven't given a thumbs up yet, please feel free to do that. It would mean a lot to me. It lets me know that you dig what's going on. It also helps out the channel analytics, which is always fun. Matthew writes in, hey, Doc, is it normal for symptoms to come back a few days after Solumedrol? All my symptoms went away during the steroids, and now intermittent ataxia is back along with the trigeminal neuralgia. So the concern there, Matthew, is that maybe the attack was incompletely treated. That's a situation where I would call the treating neurologist right away and say, hey, I've got a return of symptoms. I'm concerned that we're not fully treated. Do I need more steroids or do I need something else? That's the first thing that I would think of. A second option would be concern for possible infection, because if you had a superimposed infection, that might kick things up also. So Nitz writes, Dr. Boster, I had lesions disappear between my last two MRIs. How's that possible? Well, the word lesion references a spot. And those white spots, which are technically called T2 hyperintense lesions, that's the white spot, is representing pathologically a pool of water, a microscopic pool of water. And it doesn't tell you that there's new damage or old damage or that it's healing or that it's becoming damaged. It doesn't tell you anything about it. It just tells you where it is. And so if you imagine a pool of water could be reabsorbed and it could resolve. And if there wasn't a lot of structural damage to the tissue underneath the pool, as it's reabsorbed, it may just go away and there's no residual. So that's not common, but it does happen in the setting of MS. Pedro writes, can you talk about smoldering MS and the trials on how to stop slowly expanding lesions? So Pedro is touching on some contemporary topics. Smoldering MS is an idea propagated by some really, really smart guys. In particular, Gavin Giovannoni from Bart's MS talks a lot about smoldering MS in his blog. And if you guys are not familiar with the MS blog, you should 100% check them out because they're amazing. There's several top MS neurologists. Klaus is another one. So they talk about smoldering MS. And it's this idea, Gavin gives an example that MS conceptually is like a shredder turned on low. So it's slowly in the background shredding your brain. And you can also think of it as like a smoldering slow burn. And he calls that the real MS. And then you have these acute bouts of inflammation on top. And many of our therapies are anti-inflammatory, but they may not be very impactful at treating smoldering MS. And so, there's a lot of hope that we can impact that. I don't think that it's ubiquitously accepted concept, smoldering MS, but I certainly find value in it, in thinking about MS and making sure that I stay honest with myself about what our therapies can and can't do. By the way, if you guys look in the back, that pillow of the Highland Fuzzy Cow was given to me by a patient. We shared that we both thought Highland Fuzzy Cows were amazing. The next time they came in the office, they gave me that pillow, and I love it. And that's a painting that was passed down to me from my mom, from my grandfather. My grandfather painted that, and I always think of it's kind of like a portrait of my grandmother. All right, so let's see what else we've got cooking here. Jen McGraw writes, hi, Dr. B. Do brain lesions have the ability to impact physical symptoms, or will only spinal lesions? No, brain lesions can also impact physical symptoms. So let me give an example. So if I want to wiggle my finger, that wiggling of the finger starts here in the frontal lobe, where my brain says, all right, guys, we have to get ready to wiggle the finger. Then it sends, there's messages that are sent. And there's actually a strip of brain, like right here, which controls that. And so this strip of brain sends a message from the surface of the brain down through the base and the center, the base of my brain, the stem, through the spinal cord, then out the spinal cord to a bunch of nerves down here to control the muscles to make me wiggle my finger. Damage along that entire pathway from the muscle to the neuromuscular junction, to the nerve root, to the plexus, to the spinal cord, to the base of the brain, to the subcortical white matter, all the way to the cortex. Damage from anywhere along that pathway can result in the symptom of weakness. So it's not just spinal cord damage that can cause arms and legs to have problems. It's also the brain. Good question. All right, so LC question. Hey, Dr. B, I love your channel. Well, thank you. Let's see. Are B cells the same in terms of how effective they are? My doctor says Kesimpta and Ocrevus are the same except for administration. So your doctor is not capable of knowing that, as is no one on planet Earth, because there's been no head-to-head comparison. So there's no study of Kesimpta versus Ocrevus. Now, we all may have opinions, and they're like noses, they all smell. And my opinion is that they're both B-cell killers, and that they both have very similar mechanisms of action. As far as which one's better, I think the jury's out. Now, everyone can have a preference for one thing or the other. Someone might like Pepsi better than Coke, but without data, we're guessing about their efficacy comparatively. All right, so we have been doing this for 58 minutes. I'm going to do this for maybe another question or two. So Lisa, my brother has end-stage PPMS, and my sister got a home to get him out of the nursing home. We can't find an appropriate PCP care. All want him to think about end of life only. Any ideas? All right. So first of all, a visiting PCP is maybe the way to go. Someone that's going to come into the house. I also want to share with you that considering palliative care or even hospice care is not always a dumb option, because if you qualify for palliative care or hospice care, oftentimes there's all kinds of resources that can come into the home. And a physician can say that it is a reasonable expectation that he could succumb within 6 months, which makes him eligible for some of those things. And if he doesn't succumb in 6 months, God bless, you can say it for another 6 months. And so you can actually be in a palliative environment for years and years that way. So we're just hitting up against an hour. This has been an absolute blast. I want to thank everyone for joining in. I want to thank Matt Z specifically for his willingness to help with moderation. I want to thank everyone from all around the globe that jumped on. One of the fun things that I get to do when a live stream ends is I go back and I read through all the comments and I copy the questions I didn't get to prepare for other videos. If you are listening to this, I would love to hear from you what kind of content you want to see and specifics are helpful. Again, my name's Aaron Boster, and as always, thank you for learning about MS with me. And until my next video or the next time I do a live stream like this, or the next time I see you at the Boster Center for MS, be safe and take care.